Hey Fabio,
Hey boss, what's going on?
you reading some EEGs?
No, I have a patient in clinic. It's an adult, has epilepsy, but it's really unexplained. And some people say I should get genetic testing, but I don't really understand why.
Yeah, they're hard to interpret for people like you. Maybe we
Yeah,
should get an expert.
okay, let's do it. Dr.
Uh,
Helbig, welcome.
Thank you. Thanks for having me.
Yeah, thanks for coming. Please enlighten us. Really excited to have you.
All right, so what I'm going to do is I'm going to try to give a crash course for epilepsy genetics for what we in the pediatric world refer to as adult epileptologists, so epileptologists for adults. Yeah. So I'm talking about genetic testing in adults with epilepsy, and I'm going to kind of break this down into like three different items.
Who to test? What tests are available? Yeah. So what should you order from like this big menu of lists? And then what to expect to use this. These three icons are typically called the big three. Yeah. So this is what we typically think about in epilepsy when it comes to diagnostic. Brain imaging, EEG, and genetics. The first thing I'll tell everybody is just think of genetics as the very same thing as an EEG or a brain scan. It is a diagnostic test. We know this very well from kind of clinic that we have situations where things don't fit, where a patient is doing exceptionally well, but the MRI looks kind of strange, or the EEG shows us lots of kind of slowing or abnormalities, and typically we tend to believe the patient and not the EEG. You know, what I'm trying to go against is this kind of concept of genetic exceptionalism. Yeah, so genetic exceptionalism, that genetics is like this strange test that takes precedence over everything else. Yeah, so just think of this as a component of the big three. It's one of the diagnostic tests that we get. And this is like this kind of like this change of concept.
Okay.
Genetic testing has gotten easier, has gotten cheaper. Yeah. And
You're
so this is
saying,
what we're trying to do from the genetics community, just to kind of think of this as something that's kind of standard. Wanted to give you this one slide about progress in like gene discovery. And this has actually changed quite a bit. So genes look like this now. This has actually been a very,
whoa.
very exponential increase in genes
Mhm.
that cause epilepsy.
Mhm.
For the, let's say, adult epilepsy field, many of these genes might not be all that relevant because many of these genes cause developmental and epileptic encephalopathies. Yeah, so those are severe uh, encephalopathy genes or neurodevelopmental disorder genes, but we still find them in adults. And I'll come back to this in a minute. Yeah, so there's this kind of like ongoing increase in new genes, and that is perfectly fine if these things are just kind of letters and numbers for you in the first place. Yeah,
That's
half
what
of
they
these
are.
things I need to look up to. I have no idea what they do. And then there's other things. And this is maybe important, especially like genes have different evidence. I'm working as part of a group that's called ClinGen, and we evaluate genes for how valid they actually are. Yeah. So spoiler alert, not every gene that was kind of published is actually a true gene. Yeah? So some of these genes that sometimes you still find in textbooks, they've actually been disproven. And just imagine that this kind of lags behind. So if we publish something now, it's been written last year or something, yeah. So that there is something like an ongoing what is called gene curation. This is from an epilepsy paper that we put together with Juliet Notes and the Epilepsy Genetics Commission. And this is about like which genes are more prominent. And this is like taking that so-called gene panels. And this is already a few years old, but this looks at the number of gene panels in kids and just gives you an idea of what genes we find if we put this all together. Yeah, you can see SCN1A at the very top here, KCMQ2, SCN2A. So those are some of the genes that we see in children. Main thing is that you actually look at the x-axis here at the number of variants. So 600 variants. So in this like 1 or 2 year time frame when this was published, there were like 600 people diagnosed with SCN1A, most likely Dravet. Yeah, so this is relatively common, and if you search, you can actually make a diagnosis in a significant number of patients. In children, we have like roughly 30%. It's higher when the presentation is more severe and earlier, yeah, and it's lower if we're just looking at like, yeah, epilepsy without developmental difficulties. Yeah. Mechanistically, I'm going to give you like the two big classes. So the two big classes for epilepsy genes are ion channels and synapse genes. There are many, many others. Yeah, you remember this like big list of, but those are the two things I want people to remember. We think about like ion channels or synapse genes. Yeah, and ion channels are of course the one where we have some therapeutic options, and with Dravet being like the most common one. this is kind of a meta-analysis from 2021
Mhm.
about the yield of genetic testing. Yeah.
Hmm.
And you can see there's actually quite a bit of changes. There's some studies that give you like 80%. Yeah. There are some studies, many studies are in this range here, and it's like 20, 30%. This is one of my studies here, 2020, and with like 0%. This was FIRES. Yeah. So
Oh.
Febrile infection-related epilepsy syndrome, there's like 0 yield. Yeah.
Hmm.
And you can see this actually varies quite a bit, but if you try to get a rough estimate, you end up as like roughly 24%. So this is across all studies. This is what we think of. 1 in 4, 1 in 5 individuals with epilepsy has an underlying genetic cause. And this, of course, depends on what type of epilepsy we're talking about.
This chart is across all ages?
So many of the studies have been done in patients who are younger and have epileptic encephalopathy. And I think this is just important for like all adult epileptologists who kind of think about genetics, is that much of our knowledge comes from the pediatric sphere.
This accounts for all the types of genetic testing. Dr. Helbig, I see some WESs there, maybe some panels, so all types included.
This is largely exome, so WES stands for whole exome sequencing. Yeah, and this is basically a test where we look at maybe 20,000 genes across the entire genome. And panels, I'll come to them a little later, Fabio. They kind of they look at a subset of genes. Those are mainly exome studies. Yeah?
Okay.
Here's one kind of study. It's also a little bit older, but I think this is a nice way to kind of see what's happening in adult neurology across genetic testing in general. So for dementia, movement disorders, epilepsy. Yeah. What I like here is basically this little peak here. And I'm going to play in this a little bit. So in the epilepsy field, we use gene panels quite a bit. But the main yield in epilepsy actually comes from whole exome sequencing. And I'll explain this in a minute, but this kind of speaks to the fact that we have this 1% phenomenon.
And maybe that's this one point to bring up too, Dr. Helbig. It's a lot more challenging for us to, as you know, get whole exome sequencing in adults than it is in pediatrics, right?
Yeah.
So that's why I think most people on the adult side start or end really with just panels, right?
Yeah. So and you have a yield with panels. Yeah. So it's actually not bad, but there it doesn't necessarily that translate that you can say I'm going to use the good numbers from pediatrics that show a very good yield for panels and then translate this to adults. This was the yield here as some kind of build up from like the pediatric part. So I'm going to use this just for my teaching slides when I try to explain this to trainees on which genes actually fit where. Yeah. So we have some genes that are very early in like what we call early infantile epileptic encephalopathies. And then this kind of goes on. I think when we think about adult presentations, we're in the range of Lennox-Gastaut syndrome. Yeah, those are patients that often, maintain their epilepsy when they transition. And then there are some other genes that, like GRIN2A, for example, is a gene that also carries on into adulthood. And then some focal epilepsy genes that I'm going to mention separately. And this is basically, I want to break this down into like 3 scenarios just to kind of sum this up, how I think about genetic testing in adults with epilepsies. Yeah. So first, you can say, yes, there is definitely a proportion of adults just being adult children. Yeah, it's just kind of the extension of the pediatric presentation. So we have like the same genetic landscape where we have neurodevelopmental epileptic encephalopathy genes, adult individuals with Dravet. Yeah. And this is stuff you guys, of course, know, but there's some specific features that they have later. And there's an entire, let's say, science or knowledge base building out of this. What is interesting here is that we actually have to realize that even if we take the pediatric population and just fast forward them into adulthood over 1 or 2 decades, this population is largely untested. Yeah, so there are other tests like genetically that we sometimes do that we typically don't even think about anymore in pediatrics. And this is testing, for example, like microdeletion or chromosome abnormalities. Yeah? And those are conditions that is still quite prevalent, are because they're undiagnosed, basically. Yeah. Yeah, and in many like epilepsy genetics clinics, they have almost been, they've been identified so early that they kind of go into like a different clinical pathway. Yeah. So this is one part. So adults just as a continuation of the pediatric spectrum. And this is, of course, interesting because there are some adult features in many of the pediatric genetic epilepsies that we don't even know yet. The kind of the crouch gait in Dravet, some of the kind of like unusual features, we don't even realize them as Dravet patients anymore once they're adult. And I would have a very strong assumption this is also true with many, many other conditions that we haven't even followed yet. Yeah, so lots to learn, lots to kind of see once we actually have this population that has genetic diagnosis, moves into adulthood, and we see further features. So point 2 is that scenario 2, that there are some very classical adult onset genetic epilepsies. Those are familial focal epilepsies. Yeah, those are 2 genes I'm going to mention here, and typically, I say these gene names so often that I often kind of develop some kind of short forms for them. So DEPTEC5, and NPR3. Those are actually genes that are quite interesting. So DEPTEC5 is a gene for familial focal epilepsy, and if you have, I think this is still actually true. So if you have an adult individual with a focal epilepsy and they have an affected first-degree relative, they have a 10% chance of having a DEPTEC5 mutation.
Oh, I think I have a patient.
And there was actually a very large paper coming out recently that looked at like surgical success. So you can even then stratify this and say, how are these patients doing? And then this is one way how you can almost like get very good prediction on a defined patient cohort that is not actually large enough. There are like hundreds of patients with DEPTEC5 variants to say we can even make the prognostication of epilepsy surgery more precise in this patient cohort.
What's the answer? Do they do poorly with surgery, or
they actually do quite well?
Quite well.
Yeah. So there's often that you don't typically think of genetics. You shouldn't kind of think about epilepsy, but for surgery, I mean, but for these familial focal epilepsies, they tend to respond well. This is one situation. The other situation is that there's some progressive epilepsies, progressive myoclonus epilepsies, Android-Glanborg, Lafora. Lafora typically starts in teenage, years, but the main presentation is early adulthood. So then we have scenario 3, and this is the thing that I actually want to emphasize to people. This is really important. I call them mimickers. Yeah. So and the big one there is GLUT1 deficiency. Yeah. GLUT1 deficiency masquerades as a refractory generalized epilepsy. And what we see in pediatrics is that the typical GLUT1 situation, patients who have like really this kind of response to fasting, who have like this very typical early onset epilepsy, they've already been diagnosed. And what I tell my trainees always, it's the patients you don't expect. This is one thing. There's so many atypical presentations of GLUT1 that there's really a yield for this, and this is really good because there's an easy treatment, or you can at least offer to say that they respond well with cognitive issues and epilepsy severity to ketogenic diet, maybe modified Atkins diets, and this gives you just another option. And then very rarely we have neurometabolic disorders that can present atypically, but this is just a very, very small fraction.
GLUT1 is a big kind of, give a little bit of shout out here. It's actually a very interesting disease because it kind of affects the glucose transport of the blood-brain barrier. It's almost like a glucose starvation condition of the CSF of the brain. And this is, we typically think of our endothelial cells in the brain as just like passive filters, but they're actually very active pumps. So basically our blood is actively drained of nutrients, of glucose, while the blood flows through it. And ketones are also transported here. This is how the ketogenic diet works. So you can say our brain cells can run on ketones and glucose as one of the few tissues that can actually do this. And you can boost this one here, while this one is only functional to 50%.
I wanted to now address the question who should not get tested. Because this is not a test, it doesn't make sense to test anyone. It's not that we try to withhold a diagnostic test from anyone, but there's data, what is useful, what is not useful. So genetic testing is indicated. I think more broadly, I would say when knowledge of the molecular pathology is helpful. And this can help with understanding what is going on with prediction and treatment. This is how I would put this very, very broadly, where you can say it would help me to know where this patient's epilepsy is coming from. There are some conditions where there's actually a very, very low diagnostic yield that we wouldn't even test this. So when we think about GGE, juvenile myoclonic epilepsy, and this is a non-refractory situation. We know this is a genetic epilepsy because we know that there's a very high likelihood that a twin would have this too. But this is a so-called polygenic condition. So 1,000 different common genetic variants add up to giving us an epilepsy risk. And we know that the monogenic yield is, far below 5%. This is not like the contrast to like the refractory cases where you have to say it does actually a higher yield. But if you have a patient asking, where's my epilepsy from and can we do genetic testing? Of course we can do this, but under the assumption that this is going to be negative. Up to this point, that is call these situations almost like rule out situations. I call them GLUT1 rule outs. It's the only gene we're really interested in. It happens very rarely that we find a true monogenic cause, but the yield is very, very low. So, and then sometimes genetic testing is not meaningful if we have a known pathology. And this almost like goes without saying. So if you have an epilepsy due to a brain tumor, there's no, you can say, why does this cause epilepsy and why does a similar brain tumor and someone else does not cause seizures? But the answer is not in genes. So it's extremely rare that you have like a double hit where you can say a genetic epilepsy was triggered by a lesion or was triggered by a bleed or triggered by like a structural injury. So this is one thing to know, that sometimes when we say we have a brain lesion, an acquired brain lesion, and this is very epileptogenic, it's in the lesion. It's not in the genetic makeup of this person. We're not there yet. There might be risks for this. There might be polygenic risk, but it is not very common. One thing to know, though, is basically when we think about cerebral palsy as a condition, there's a separate genetics of cerebral palsy that's almost like independent of lesions or not. And there's if you have patients who have like a very classical cerebral palsy picture, and maybe the image doesn't quite fit with the severity, there are some separate genetic palsy genes that are almost like related to, some of the movement disorder genes or spinocerebellar ataxia or HSP.